Intra-articular type C fracture of the distal humerus. You will perform this exercise on a foamed model. However, for demonstration purposes, the different steps will be shown on a bare bone model. Here the type C fracture as it may present itself on the initial X-rays. By gentle traction on the flexed forearm, the fragments reduce themselves by ligamentotaxis. It may be advisable to take new X-rays under traction. This guide facilitates pre-operative planning, which should always be done in such a complex fracture situation. This is the type C3 fracture you will encounter in your foamed model. For the final fixation, the plates should be placed at right angles to each other. The reconstruction plate lies on the dorso-radial side of the humerus. The 1/3 tubular plate acts as a buttress on the ulnar crest of the bone. For surgery, the patient is placed in a lateral or prone position and the humerus abducted at a right angle on a radiolucent support. The entire arm is draped and freely movable. It may be useful to apply a tourniquet for a bloodless field. The fracture is exposed through a straight incision from the back of the humerus to the ulnar crest, curving slightly around the olecranon on the radial side. The ulnar nerve must be identified. We have approximately indicated the landmarks, epicondyles, and olecranon on our model. The incision starts in the humerus and gently curves radially around the olecranon to the ulnar crest. By cutting down to the bone, you will open up a periosteum-like sheath which covers the fragments. Use the tissue retractor to hold the wound open. The ulnar nerve, the triceps tendon, and the olecranon are identified. To get an adequate exposure of the articular fragments and to judge their accurate reduction, it is advisable to perform an osteotomy of the olecranon, turning the triceps muscle proximally, as shown on this drawing. A chevron osteotomy is preferred to a transverse cut, facilitating reconstruction by tension band wiring. The level of the osteotomy is marked. Using the oscillating saw, only 4/5 of the bone are cut. The final bit is broken off with a chisel, and the olecranon is reflected proximally. Back to the foamed model. The cut tip of the olecranon is elevated and reflected. In case some foam has penetrated into the fracture, it must be gently removed, just as you would clear the fragments from fracture hematoma. The fracture situation may now be assessed and the reconstruction started. In case of an intermediate fragment between the capitellum and trochlea, it is advisable to first drill a K-wire into the radial fragment by means of the inside-out technique. Therefore, the blunt end of the wire is sharpened by an oblique cut. Because a 3.5 millimeter cannulated screw is to be used, a special 1.25 millimeter guide wire with threaded tip is selected. The fracture is now being reduced anatomically and held in place by a pointed reduction forceps, care being taken not to damage the ulnar nerve. The threaded guide wire, which can also serve as a reduction aid, is now drilled in the reverse direction, outside in, all across the 3 articular fragments. The correct reduction of the fragments, especially their rotation against each other, must be checked, because at this point it can still be corrected. The length of the 3.5 millimeter cannulated screw is measured with the special measuring device, taking into account the short bit which was cut off. The hole for the screw is prepared with the cannulated drill bit. The drill guide with stop may be adjusted in order not to penetrate too far, which may lead to loss of the reduction or the guide wire being pulled out. The cannulated tap is used only to give the screw a good start in hard cancellous bone. Insertion of a 3.5 millimeter cancellous screw. Tightening the screw induces interfragmentary compression, securing the articular fragments to make one block. In our rather stiff foam model, the insertion of this first and important cannulated screw is best performed through a separate incision over the radioepicondyle. The assembled articular fragments are now reduced to the shaft of the humerus and preliminarily fixed with K-wires and/or pointed reduction forceps. The template of a 6 or 7-hole reconstruction plate is placed on the dorso-radial aspect of the bone. As the articular surface does not extend far posteriorly, the plate may be contoured accordingly with the bending pliers for reconstruction plates. Much care has to be taken for accurate contouring. The first 2.5 millimeter hole is drilled in the capitellum. The length is measured with the depth gauge. After tapping, the 3.5 millimeter screw is inserted. A second screw is placed in an eccentric position in the humerus shaft fragment. Here is a brief view of the situation in the foamed model. We now move to the ulnar side of the humerus, where a slightly pre-bent 1/3 tubular plate is placed on the crest of the bone, so that its screws will lie in the frontal plane. The first screw crossing the fracture line must be introduced as a lag screw. The near cortex is therefore over-drilled with the 3.5 millimeter drill bit. Length measuring. Tapping. And screw insertion. In case of a 6-hole plate and good bone quality, as in our model, the addition of only 2 more screws, one at either end, will suffice. The screws are tightened. Back on the radial side, we complete the fixation by adding a few more cortex screws, their number depending on how well their purchase is in the bone. At this point, we advise you to take an intraoperative X-ray to make sure there are no surprises. In the presence of soft tissues, as in our model, the ulnar plate cannot always be placed exactly at a 90-degree angle to the radial plate. The 1/3 tubular plate should, however, engage the rather sharp crest of the ulnar epicondyle and act as a buttress plate. That is also why we prefer this light plate to the heavier reconstruction plate. Finally, the olecranon is reduced and held in place by a pointed reduction forceps. First, a transverse 2 millimeter hole is drilled into the ulna, 2 centimeters distal to the osteotomy, and a 1 millimeter cerclage wire pushed through. Two 1.6 millimeter longitudinal K wires are placed parallel to each other through the olecranon into the ulna. The figure-of-8 wire loop is fastened, in slight extension of the elbow, and tightened. The K wires are cut and bent. Now the K wires are completely sunk into the olecranon. The final aspect of our open reduction and internal fixation of a type C fracture. With good reduction and good fixation, this arm may be moved immediately. A splint will not be necessary. The other possibility is shown here, using two twists in order to fasten the cerclage wire in a symmetrical fashion. All that is left to do is to carefully close the often contused and delicate skin. The final X-rays taken of our model